Welcome to the Resilient Performance Podcast. This is Keep It Real number 37. Wanted to talk about something that we kind of get asked a little bit about on a not a regular basis, but every so often, is kind of like how we blend all sorts of different schools of thought or different sorts of con ed courses and different sorts of skill sets together. What do you guys want to start it and run with it?
It's like the Bruce Lee thing where he talks about, you want to be formless like water because water can take the shape of any cup, but you also need the cup and the structure. So the structure is your model, right? You have to have an overarching framework. But I think a lot of times, even people who refer to us, like some of the physicians, they refer to us based on maybe like one thing that we do. And, we'll get referrals like, hey, we found out about you from this place and we want to come to you so you can do this thing, when that thing oftentimes isn't the thing that they actually need. And so they have a preconceived notion about what we do based on like a particular certification or course we may have taken. I don't think that we identify with any one thing. So it's sometimes like a little frustrating for us. I think there are probably times maybe earlier in our career where like we would take a course in something and you get excited about it. Like that's kind of what you do to the exclusion of other things. And then you realize that that one thing has limitations. And then you try to remember like, oh, actually I have this other skills, this other knowledge base too. And then it becomes more about how do you connect all those different things versus like having the one thing. So it's, whatever the toolbox analogy, it's like tools are great, but if you don't have a way to properly employ those tools, and that should be your model, right? Then you're just going to be you're going to be very limited in what you can do with people.
I think sometimes like the purpose of them, people almost try to apply the methods of the model just for, and that is kind of their goal, is to apply those methods that they use in a specific model without having, the goal is like the outcome is really what we're chasing. It's not like doing this specific exercise. It's like, what's our goal? What's our purpose with getting somebody to lift weights or run or whatever, not necessarily using specific drills or specific exercises. So I think knowing what is like the outcome that we are kind of chasing helps us not be dogmatic in the application of different, models that we've learned over the years.
Right. And if we have somebody who's coming into to see us for physical therapy and we don't know what they're coming in for beforehand, it's a clean slate and they should be showing up and they should expect to get what they need, not what we are like preconceived notion of what everybody needs. So we have to kind of fit people or fit our skill set, fit our toolbox to what the person needs. And yeah, it definitely happens, like Doug said, often where somebody thinks that they need something in particular, and it's almost like we have to kind of persuade them that maybe they do need that one thing also, but maybe they also need more of other stuff. And it's just a matter of like educating people on what the different sorts of skill sets do and what the other, what tools we have in our toolbox and what are some things that can be applied appropriately. And yeah, I mean, if you only, like Doug said, again, we've taken all these courses and certain schools of thought, and if everybody's tried to fit into that sort of model, we're definitely going to be failing people. So we're just trying to we're trying to be successful with people and give them exactly what they need based on what their goals are and what their injury is or whatever they're coming in for. And there's no one specific thing that everybody needs, right? So we're trying to be generalists, but have special skills within all of these different general areas, let's say.
Yeah, that was like one of the best pieces of advice I've gotten from our mentor Alan, who I remember him telling me, he's like, everything works, but not everything works for everybody. And I think that was like a light bulb moment for me, because it's like when you're kind of initially learning different models, you think like this is the end all be all and this is going to work for everybody all the time, which is really like not the case. And the more you learn and you're exposed to just like other schools of thought and other practitioners and professionals, like you kind of realize that like nothing is new, everything's kind of the same, everything's always kind of doing the same thing. People just have different explanations and rationale for like maybe how something works. But ultimately it's like we need to be knowledgeable enough and skilled enough to decipher between all the different options that we have at our disposal, all the different tools in our toolbox to apply to the person in front of us for again the outcome that like that person's looking for, not for the outcome that we think that they need necessarily.
Yeah, and I think that like our probably, and what I think the profession's identity, overarching identity and lens should be is function, right? So it's like someone comes into you and they have pain, or maybe they don't have pain, but they have limited function. They can't do something they want to be able to do that's movement related. They're at point A. How do you get them from point A to point B? And we're agnostic about how to get them there. And it could be a lot of things, right? It could be biomechanical, it could be fitness, or kind of like a progressive overload, load management type scenario. It could be, more like psychosocial, where they have a preconceived notion about something, or some kind of apprehension or anxiety about movement. That's why they can't do it, not because they have any kind of pathology. And it's our job, and I think the profession's job, to tease out which of those variables, it could be a combination of them, is contributing to that lack of function. And it's always contextual, because I know that like right now the field is shifting more towards an identity of being like very exercise based, and there's kind of a little bit of like an anti-manual therapy backlash, but everything has a place. And because I was just, as you guys know, in San Diego, working with an ultimate Frisbee team here from New York, where I was basically more of like just doing kind of acute in-game care, and then helping with, recovery and treatment in between the games. And like, these people are playing 3 games a day in some cases. One of them had like a tracker on, and I think ran between like 13 and 15 miles in one day from playing 3 games. It's like playing 3 soccer games. So it's like, all right, you have someone and they're presenting with what looks like an Achilles type tendinopathy. Am I going to have that person in the middle of the game doing like isometrics or eccentrics when they're running around? It's like, no, I'm going to like rub their calf and hope they get some transient relief. So, and I've seen even, like videos on the internet where it shows like an athletic trainer or a physical therapist on the sideline, like doing like a manual technique of someone, and all these snarky physios are like, oh, like manual therapy sucks. It's like, well, what are you going to do in the middle of a game to somebody? It's like, you're just basically, you're going to try anything to get a little bit of relief. And then after the game or after the tournament, then you're going to do kind of things that might actually like be the long-term fix. But I think that any physio or sports-minded physio like should work in an acute environment, and then work in a more like rehab-centric outpatient environment, because you see like everything does have a place. And I mean, we all work with people who maybe they are very active and like they don't need the exercise component from us, but what's going to help them, maximize their function and help them achieve their goals, it might be something that's a little bit more passive. And there are people who, don't do enough, and that's where we're going to push them more. And then there's a whole psychology piece that goes along with that, because everyone has some kind of psychological component to whatever goal it is they're trying to achieve. So yeah, it's being agnostic to the method, but I think the overarching framework needs to be like, you have a functional goal to achieve, whether that's playing 3 games in an ultimate Frisbee tournament and trying to win a national championship, or it's just being able to walk up and down the stairs without pain. But I think the overarching goal needs to be like, how do we maximize function relative to the person's goals?
Definitely. And it's like, if we were a siloed professional, and it's like we're weights guys, or we're a kettlebell guy, like all we do is kettlebell stuff. Like, what are you going to do with that person who's coming out of a game? And or maybe you're not even there for acute care, you're there to see them the next week, where they still played essentially 3 games in one day, ran 13 miles in one day. Like, they probably don't need more work. Maybe their training leading up to the game might have required more work, but still, like, somebody's running that much in one day, like, you're gonna have to put out fires at some point. And doing some manual therapy is definitely gonna be useful. And like, if you're just going to be doing kettlebell work, it's probably not the one thing. And again, I'm not saying kettlebell work is bad. I'm just saying like that's one tool on the tool belt, and we have to be able to use all these different things when they're appropriate.
Yeah, and it's also, people talk about like, well, they'll cite studies saying, well, like in 10 weeks, it doesn't matter what you do, the outcomes are the same, which is, I mean, a completely kind of crap argument, because I could, and this is an extreme case, but it's the same logic. I could say, well, because like when I was in the military and did medical stuff, I could say, well, this person, got blown up on the battlefield. I'm not going to give them pain medication because in 10 weeks it won't matter anyway. It's like, having, having a knee that hurts going down the stairs isn't the same as getting like a body part blown off, but it's still like, it's someone's subjective experience. They might be in some discomfort. And if you have the ability to, alleviate some of that discomfort, like why would you not do it? Now we can get into whether, what the healthcare system and insurance should pay for as far as that goes, because you can take it too far, right? But like, let's just make it easy and say someone has the means, they're willing to pay to alleviate their discomfort. Why would you not do it if you have the ability to do it? Like, you're going to tell someone who's willing to pay you to alleviate their minor knee pain going on the stairs, well, don't worry about it, because like, yeah, if you just do these things in 10 weeks, it won't matter.
If you don't do anything in 10 weeks, it'll be,
I mean,
it'll be different.
yeah, like that's not like really that ethical or humane. If you have the
Yeah, it's
ability
like,
to help
why do
somebody,
we-
you don't.
Is that
No.
why we went to school? We went to school
Right.
for that.
Yeah, because you could, I mean, if you extrapolate that logic, you could just be a nihilist and be like, well, nothing really matters. It's all going to be the same. So why do we even have a job? Like, so I think, like, yeah, it's important to have that research, because you can, that way you can have a reference to give people options. You could say, look, like, we could do this thing, because in the real world, there's trade-offs. You could say, yeah, like, you could do this injection or this course of therapy, but it's going to cost you this much time and money. In 10 weeks, it won't matter. But at least if you say, like, this is what it costs to get these things done, then the person can decide. And they might decide that it's worth it. I've been in situations like before my back surgery where, like, I paid out of pocket to get an injection, knowing that I probably in a couple of weeks would have been a lot better. But it's like when, you have trouble like walking more than a couple of blocks because you have a nerve being crushed. It's like, yeah, I was willing to pay whatever it was, like $1,200 out of pocket for an injection or whatever it cost, because like at that time, like my short-term comfort was more important than knowing there was a study saying that in 10 weeks. And again, even getting the injections, it's not certain that I would have gotten better, but it's like when you're actually have experienced some of this discomfort, you can appreciate why. And again, a lot of physios get snarky about like, oh, this person did like whatever modality they don't like. But if you've been in enough pain, you'll kind of try anything. So, and I think it's our job to figure out like what's actually the best use of someone's time and what's not. But I think to say that like it doesn't matter what we do because it's all going to be the same in the long term is like that kind of defeats the purpose of our profession, in my opinion.
And hopefully the 10 weeks specific, like that research is more specific to certain conditions or something like that. But I do remember in PT school talking about some sort of research, certain conditions where it's like if you compare PT to doing nothing, like the outcomes were the same. I think it's more condition specific, but maybe that's more a problem with the model of how PT is delivered too. Like if you're working in network, it's really hard to help people sometimes if they need the attention. So that's a whole different problem, and it's not necessarily related to what the person is capable of doing as a therapist. It's more the model that they're working in that's the limitation. So yeah, I don't know what that research exactly was about, but I'm sure it applies to a lot of things, but hopefully it's not everything.
I think like taking somebody's subjective experience into consideration is super, super important. And that's like not something that you kind of really learn without actually treating people. And I definitely think Doug's point of like having some of those, experiences of injury and pain allows us to have like empathy for our clients when they go through stuff to help us try to, navigate what might work for that person kind of in that moment. And that's why I think like I would say like one of my weaknesses as a clinician is it's like if I can't coach something or if I haven't had something done to me and I don't really know how it feels, I have a hard time giving it to somebody. So it's like kind of experimenting with that stuff yourself. If you like Doug, like going through an injection helps you have an understanding of like when somebody may actually need an injection versus just kind of randomly saying like, yeah, why don't you go get an injection for maybe pain that's not that serious or not that extreme.
Yeah, and like going back to this ultimate frisbee example, like if you've never run a mile before, like it's hard to kind of understand what it feels like. And then obviously if this person's running 13 miles, like that's an experience that most people probably don't really understand. Like I've never run 13 miles in a day, so that might be hard for me to relate. But it's going through kind of getting beat up and feeling things, and is sometimes a really great educational process for a therapist. And then you can almost like predict or kind of tell people what they are going through, and they're usually like confirming like, yeah, that's what it feels like. And it's just that's a great way to kind of build some trust too.
Yeah, and it's a little bit, I mean, we're deviating a little bit from like the original model conversation.
Yeah, that's fine.
I think we've kind of like we've hit on, yeah, you need to have some structure, but at the same time you have to be open-minded and, goal-oriented about what the person wants to achieve. But like I told you guys, I was working with a girl who had 2 ACL surgeries, a meniscal transplant, and she's at a point now where she's young, I think in her mid 20s, and there was some discussion about like the definitive treatment for her is to get a partial knee replacement. But some of the surgeons are saying, well, like we don't really want to do it now because then you're going to need to have, a third knee replacement when you're 60 years old or whatever. And I'm just kind of, I mean, my thinking is like, why, ruin your present just for the possibility that, to save time in the future. It's like if you're in your mid 20s, like that's kind of the prime of your life. And if you're suffering, like yes, it's not the textbook thing to get a partial knee replacement in your mid 20s. But I mean, if it's me and like I've tried everything and I'm not going to get better doing anything but getting the partial knee replacement. I'd rather feel good in my 20s and then worry about getting my third knee replacement when I'm 70, than having to like, it's like, well, let's wait till you're 35 to get the partial knee replacement. It's like I've got to suffer for 10 years in the prime of my life when I can get a partial knee replacement and do 90% of what I want to do. To me, it's almost like a no-brainer. So we have these things where it's like we're always talking about the future and the future. And it's the same thing with the idea of like, well, I'm just going to keep working really hard now. I'm going to put my life on hold. I'm not going to see my kids so that I can make enough money to live my life later. But later might never come. And if you have that mindset, you're just going to keep pushing back the later. So there is something to be said for like alleviating discomfort in the short term. And I think sometimes like we can take these studies too literally where we say, well, again, like, yeah, the textbook thing is to get the knee replacement when you're 35 because you won't need more in the future. It's like, what about the quality of your life right now? And that's like, we're humane in so many other areas in medicine, but then when it comes to stuff like this, we forget that, these are like people in front of us, not robots or like these just participants in a study. Like it's a person that wants to feel better right now.
Yeah, I think like that point of like people we're always worrying about the future. Like I've had a number of clients, I'm sure you guys have to, where they've been told by somebody, some other medical professional, that if they keep doing X, then in 10 years they're not going to be able to do Y. And it's like when people hear that kind of stuff, it kind of makes them change their behavior in the moment in a way that's often not just like stopping running 15 miles a week or whatever it is, but it's kind of makes them fearful day to day, and that really like changes somebody's quality of life. And that's one of the things that like has always kind of bothered me. It's like when people kind of have those huge generic statements that ends up really changing their day-to-day experience. And it's like our job is kind of help alleviate some of that frustration and anxiety that can be caused from some of those kind of fear-mongering type of statements from people.
Yeah, and I think a lot of times the stuff that people are told they shouldn't do, it's really just dumb. It's like, well, your knee hurts, like you shouldn't ever do squats. It's like, okay, well, what does that even mean? Or like your Achilles hurts when you run, so you shouldn't run. It's like, all right, like till when, But I think that the bigger thing with that is it's not really our job to tell people like what they should and shouldn't do. I think it's our job to more educate people that like, hey, okay, if you do this, here's potentially the consequence down the road, but let the person make a decision. It's like if you inform them that like, yeah, because I do things that probably will make me not feel great when I'm 80 years old, but like I'm okay with that trade-off, because again, I'm not like, I don't want to just totally abandon the present for some possible vision of the future that might never come, right? So it's like you can tell people like, here's the possible consequence of your actions, but like you decide, versus saying like, you shouldn't do this again, because how do you know what like someone should or shouldn't do? How do you know what's like meaningful to people? It's kind of like saying to like the doctor or the physical therapist, like, well, you shouldn't do your job because it's stressful and it makes you unhealthy and it takes time away from your family. It's like, let me decide like how much I want to work and how little I want to work. So there's a lot of paternalism, and oftentimes it's paternalism with bad information too. It's one thing to tell somebody like you shouldn't do this because it's actually dangerous, but there's a lot of, in our field, you shouldn't do this and stuff that's not even dangerous. It's just like Trevor said, fear mongering.
Yeah, and like another example of that sort of thing, and like messaging with a patient and age and how that all plays out. Like I have a patient now who's, I think he's 75 or 76, and he's, since he was 20 years old or whatever, been like essentially powerlifting, but not really powerlifting. Like he just likes those lifts, so he does those more than anything else. And he's like 75 years old, and he was able to like deadlift, let's say like 315 and like squat 225 and he like tore his hamstring. So for me, it's like, all right, well, you can rehab this. Like, those numbers I don't think are so outlandish that you can't get back to them. But if he goes to any sort of doctor, like I would fear for him just going to any doctor you just kind of Google, because they might just say like, well, why are you lifting weights? Like, you're 75, you should just be chilling. And it's like, this guy really loves to lift weights. So like, let's figure out a way for him to lift weights to the degree that is safe for him and he's able to do and like can progress to. And the expectation I gave him is like, this could take you like 6 months to a year even, like to kind of feel normal, because it was a really significant like avulsion fracture proximally of his hamstring. So that's another reason why we like working with certain physicians, because the messaging isn't necessarily like catastrophizing. It's more like, all right, well, what do you want to be able to do? And it's like, do I think that's safe and realistic? And if so, then let's do it, and let's just like be smart about it and take our time.
Yeah, and that's kind of like, if we're talking about like models, like that's the heart of the psychosocial model. It should be, the big component of that is like, what is the patient value? I think we forget that a lot of times, because we're supposed to be the experts, so we tell them what they should and shouldn't be doing. But if everyone talks about biopsychosocial model, like patient-centric model, but like that patient-centric care is like, what's important to you? How can we help you get there?
Yeah, and you wouldn't believe this guy's like hips. You look at them on the table, they're beautiful. Like, you would think a 75-year-old guy who's been squatting for 50 years coming in would like test terribly orthopedically. Like, this guy's got tons of range of motion. He's got a full like ass to grass squat. It's pretty awesome. So it's like him presenting with that, and he also like didn't really have much pain like initially. Like, I think you can do really well. I think you're going to do really well because you're starting from a good place. So like, it's got to be specific to that person. And like you said, based on their goals and what they want to be able to do and their values.
Like how would that guy's quality of life be if you took away his ability, or like not necessarily took away his ability, but you just didn't allow him to squat anymore?
Yeah,
right?
no, I asked him that straight up. Like, all right, if you can't squat even less than 185, like if you can't squat 185, would you be like, how would you feel? He'd be like, I would be like, I'd be destroyed. Like, that would be terrible. I would feel terrible. Like, okay, cool. So like, let's do this. And if he had said like, I could kind of do without it, like, all right, well, let's figure out if there's something else that you really enjoy doing physically and you can exercise, and where you're not really like strenuously using your lower body. Also, this guy like sails across like the Caribbean Ocean as a hobby for like 6 months out of the year. He'll sail from somewhere in the Northeast, like New Jersey area. He'll sail to Bermuda, like stay there for a night, and then like sail to all around the Caribbean. And he does this with like one buddy. So he's like physically doing stuff for an entire. Yeah, no, this guy's a badass. He's also like just like intelligent, super intellectual person. And like, he's like, do you think I would be able to like lift the anchor out of the water? It's like, that's an awesome goal to be able to do. Like, it's probably more important than like, can I squat 225 ever again? It's like, can I lift this anchor so I can go sail for 6 months? Like, that's fucking sweet. That's awesome. This guy's a badass.
Yeah, that's a pretty awesome goal to be able to kind of lift the anchor for your boat so you can just go sail for 6 months out of the year.
That's pretty awesome. But yeah, I mean, we kind of went on a bunch of tangents there. I don't know what we're going to title this, Keep It Real, but this was a good one, nice and short and sweet, I think. So that's it for this episode, and we will see you guys next time.
Thanks, everybody.
Thank you for listening to the Resilient Performance Podcast. For 10% off our continuing education membership platform, please use promo code PODCAST at our website, resilientperformance.com, and be sure to join our mailing list for monthly exclusive content.